Welcome. Thank you for tuning in to this presentation from the Choices Community of Practice. The Choices Community of Practice includes people whose work focuses on advancing obesity prevention, healthy eating, and active living, and want to learn more about how cost-effectiveness analysis can advance their efforts and address health equity. The goal of the Choices Project team is to support these efforts by providing tools, resources, and training opportunities. We hope you enjoy this presentation and find it informative. Thank you for joining us.
Today I'm going to be discussing the microsimulation model that we developed for the Choices project. There are two main learning objectives for today's discussion. By the end of this presentation, you should be able to, one, describe how the microsimulation model is used to make projections into the future and estimate potential impacts of different strategies. Specifically, we'll be looking at the Choices model conceptual framework, a high-level view of how it works, what data inputs are used, and how the model results can be used to look at disparities. And in addition, you should be able to describe how we modify the model to various local contexts, depending on what data are available. The first step in our modeling process is to create a virtual population that's representative of the particular area that we are studying. We customize this population to match the population demographics, and also personal characteristics of people residing in different areas. Each person in the population has their own individual level characteristics. So they have demographics, including location down to the census tract level, age, sex, income, poverty level, and race ethnicity. They also have body measures, height and weight, which change over time, and from that we calculate BMI. And we also model different behaviors such as dietary intake of different food categories, whether they eat fast food a few times a week, and etc. We have a lot of information on people in this country, but it's not all in one place. And so we use a process called statistical matching to borrow information from several different data sets and then synthesize it at the individual level to create a more realistic virtual individual. So we take information on where people live based on the US Census, and then conditional on their age, their sex, race, ethnicity, and location, we then impute different attributes from other data sets, such as the Behavioral Risk Factor Surveillance System, which is a large telephone survey where we can get self-reported height and weight. And then we have to adjust that for self-report bias, looking at the NHANES or the National Health and Nutrition Examination surveys, where we have a smaller sample of objectively measured height and weight. We have similar processes for children from the National Survey on Children's Health. And then we also have different longitudinal data sets that follow individuals over time, looking at their height and weight. And lastly, we also will include state and local data where available. After we create the virtual population, we run the model forward for 10 years typically, so now from 2020 to 2030. And we run the model twice. First, we run what we call a baseline scenario, which is just based off of the current projections. We then run a separate scenario where we have some intervention. We've changed something in the model. And then in this counterfactual scenario, we can compare to our baseline projections and look at differences. So one of the easy things to look at is how many people do we estimate would benefit or be impacted by different interventions? What impact would this have on their BMI and obesity prevalence? And then over this period with reduced population level obesity, what would be the healthcare cost savings compared to if there was no intervention? So we begin in 2020, we project the virtual population forward for 10 years, both at the individual level, so we project their height and weight trajectories, and then we also take into account secular trends in the population. And we have an open population, which means that every year new infants are being born into the model. So a high-level view of how the model works. We start with our virtual population that's comprised of data from multiple data sets. We then look at population trends, so trends in population growth, that's with new infants coming in, and then also trends in BMI. At the individual level, we look at body growth, so how height and weight changes over time, as well as how other characteristics change over time. So smoking patterns and also dietary intake patterns over time. Based off of these, we then estimate what the obesity category is for each individual, and then we aggregate that up to the population level to get population estimates of obesity, healthcare costs, and then also obesity-related mortality and quality-adjusted life years. This is for the baseline scenario. In the strategy or intervention scenario, we repeat the same process, but we've changed something. So we have some impact usually on dietary intake or physical activity that's going to modify the underlying trajectories, the underlying weight trajectories for each individual in the model. We look at how this will then play out into the population level obesity prevalence and what impact that has on mortality, quality adjusted life years, and healthcare costs. So height and weight trajectories, each individual starts with a given height and weight in the model, and then we have to create a synthetic growth trajectory for them based off of different longitudinal data sets. And so here's one example from the same point is I've just rematched the person to different observed trajectories over the next several years. And then we repeat this several times so that we can have some sense of what the uncertainty is around their projected height and weight over time. In the intervention scenario, we compare the same person to their baseline trajectory. And here we're plotting a reduction of 1 unit of BMI. And we assume that that in this case, it takes about 18 months to achieve that BMI reduction starting at age 10. So you can see in the chart that they have the exact same trajectory up to that point. And then starting at age 10, they slowly start to move onto a different weight trajectory. So the unit reduction of BMI is really a unit of BMI that's being prevented in the intervention scenario. It's not really a weight loss scenario here, but we're moving a person down to a lower BMI and weight trajectory over a period of time, and we assume that that reduction in weight is maintained over the intervention period. To account for population level growth, we made projections based off of US Census data, and then we do this by race and by state so that we can take into account differences in fertility across the country. And when we bring in infants into the model, we use a process called bootstrapping, where we will have them look like replicates of infants who were previously in the model. And we do this at the individual level so that we maintain the covariance or the relationships between all of their individual level characteristics. For healthcare costs, we have baseline or non-obesity related healthcare costs that everybody in the model has. And then depending on their weight status, they'll have excess obesity related costs. Adults face over $1,000 in healthcare costs per year. Adults with obesity have higher costs compared to non-obesity, and this typically increases with age. Children have smaller excess costs, about $200 more than children who do not have obesity. So we take into account the excess costs of obesity-related healthcare by age. This is important to keep in mind that these healthcare costs really don't increase substantially until the mid-30s or early 40s. And that's, again, when we see large increases in risks for morbidity and mortality from obesity. So children at higher weight do have some higher healthcare costs, but it's not really until you reach your mid-30s or early 40s that obesity risks really start to be more substantial. And so when we're looking at just a 10-year intervention timeframe, we see that early childcare strategies often don't have a big impact on costs, because children don't spend that much typically on healthcare. So to get more cost savings, we typically have to look at policies that also include adults. So what have we been finding? We found that strategies need to be implemented across many sectors to improve population health. Strategies can have large reach and large effect, but to really substantially make a dent in the obesity prevalence, you're going to need to do a lot of different strategies at the same time. Some strategies we found are cost saving, which means that over time they would save more money in averted healthcare costs than they would cost to implement. This is rare to find strategies like that in cost effectiveness analysis. Usually you have to pay for some increase in health, but you usually don't save money. So this is rare that we're finding strategies that would actually save money in the long run. As I mentioned, we found that you typically have to include adults in your intervention strategy to have large healthcare cost savings because costs are much lower for kids. And so as a result, many strategies that only focus on children are not cost saving, but they require some investment in health. And so we try to find ones that give you the most value for your money, that are good investments. And we found some strategies that are projected to reduce disparities by race, ethnicity, and by income group. So a couple of examples of strategies that are cost saving. First, a sugar sweetened beverage excise tax, and also a restaurant menu calorie labeling. So we found that a national sugar sweetened beverage excise tax could save almost $15 billion over 10 years. That's net costs. So that's after taking into account the costs of implementing the tax. What are the savings in healthcare costs averted compared to how much we would have spent without the tax? And we found that it could avert 2.5 million cases of obesity by 2025. Some strategies that only focus on children that still save overall than they cost to implement, it's usually not because we are averting many healthcare costs, but because we are averting costs or implementation cost offsets. So for example, Smart Snacks, which sets nutrition standards for all foods and beverages sold in schools, would save parents money because they wouldn't be having to provide their own food for kids. Some strategies that focus on children that require investment, so these are not cost saving, which is typical. It just means that you have to pay, you don't save money, but you gain health. And so here we see that there's a wide range of how much interventions would cost to implement, and also a wide range of cases of obesity prevented. We've also found some strategies that both improve population health overall and also reduce disparities. So one example of this is looking at a sugar-sweetened beverage excise tax that we modeled for the state of West Virginia. West Virginia currently has a very small sugary drink tax, which is about 1 cent for every can or bottle of soda. And so we modeled out a scenario where that was substantially increased to be 1 cent per ounce, or actually 2 cents per ounce for West Virginia. And we see here that baseline consumption, there's a large gradient where higher income individuals drink less sugar sweetened beverages on average, and this consumption increases as you go down the income gradient. And so because there is this baseline difference in exposure, we find that if you were to implement a tax, you would have disproportionate benefits for lower income individuals. And so we found that the projected reduction in sugary drink consumption over the first year is about 4.96 ounces per day on average. That's for high incomes, but that it was almost 1.7 times greater for the lowest income category compared to the high income category.
Thank you for tuning into our presentation. You can learn more about the Choices Project, our research, and the community of practice by visiting our website at choicesproject.org.